Now, US President Donald Trump's administration has now ordered a permanent stop to support for South Africa's HIV organizations. This follows an initial 90-day freeze of all funding to foreign countries through the Pepfar USAID program. Earlier this month, Health Minister Dr. Aaron Motsoaledi said South Africa funded 80% of its HIV program from the fiscus, and that Pepfar specifically funds additional personnel and operational expenses in high-burden districts. Let's discuss the impact that this move will have on programs in the country with CEO at the Desmond Tutu Health Foundation, Professor Linda-Gail Bekker. Prof, a very good afternoon to you. Thanks very much for your time. After weeks of speculation following President Trump's initial, or shall I say, hints or comments, it's finally happening.
Indeed, and over a 24-hour period, Boyo, so really very devastating news across the country and the region in the last 24 hours.
The question really is that I don't think there was ever any doubt. It wasn't a question of if, but when. The question really now is whether during this period, over the past few weeks, the measures have been put in place to try and make up for that deficit, considering the fact that Minister Aaron Motsoaledi said South Africa funded, we're funding 80% of these programs from the fiscus. Are we going to be able to make up that 20% is, of course, the key question.
Indeed, and I think, that question has a lot of layers within it. The first is you're absolutely right. The whole region has been moving to a period or a place of self-reliance, less dependency on the Pepfar program. I think you're absolutely right. As many have said, this is not a program that could continue into, perpetuity. So we have been making headway, in South Africa in particular. But what you opened with a very important comment, that what Pepfar has been doing is filling that difficult gap of the high burden, the complex populations, the difficult or hardly reached people who aren't in our programs at the moment. And if you like, it's those difficult problems that are holding us back from really bringing the epidemic under control. So the Pepfar dollars were being concentrated in finding the people who aren't in our programs, who have disengaged from care, the people who find it difficult to come to our health facilities that are mainstreamed. And that is, I think, the critical gap that's going to be left. And unless government is able to find a way to fill that gap urgently, I think it's going to set our response to the HIV epidemic back quite markedly. And so, we need to see whether that gap's going to be filled in the short term with a medium and longer term plan, because we know this epidemic is going to take longer than just a while to be brought under control.
Perhaps, I think for the benefit of our viewers, unpack for us or give us a sense of what it means to operate in a high burden districts versus the rest or other, shall we say, normal districts.
Yeah, so in a high burden district, first of all, there's a lot of circulating virus, which means people at risk of HIV acquisition. These are ordinary people who are, going about their sexual normal lives. So the first thing is you really need to be sure that you have HIV primary prevention working well in those areas. Secondly, you do want to reach everybody who might be living with HIV who may not know that they are. Now, we are 25 years into our epidemic, so you could argue that if those people were easily reached or, were in the testing programs, we would have found them. The fact that we haven't found that, 1.1 million people that Minister Motsoaledi spoke about this week even, the fact that they're not in our program means that, they haven't engaged with the health system. They need to be found. That means we need to go the extra mile. We have to go outside of our health facilities, into communities. We need to look for them because they aren't actually in our services. Alternatively, they may be in our services, but they've disengaged for a reason. And these are all the very critical responses that the Pepfar program was bringing to bear. In addition, they were helping with collecting that data so we could really have a good handle on where the epidemic was on the rise or on a decrease. And of course, they were providing a lot of the technical support to the health system in order to make sure that this was happening. So this is what I see as an enormous gap immediately. And I'm really hopeful that, the Department of Health is finding ways to fill that gap, or else we as a global national community need to come together to say, how are we going to find the resources to make sure that people don't fall through the cracks?
And do these high burden districts include metros? And I'm asking this because only the other day, the same day that the minister spoke about these issues, among the challenges that were identified was that men in particular don't easily and voluntarily come forward for HIV testing. And the other factor was the fact that a lot of some rural but also areas where there was abject poverty were also at a disadvantage. And the DDG of Health sort of made an important point that I wasn't aware of, that in fact, it's not like it's happening only in those areas, but also in the metros where there are a lot of people, there's a lot of migration and the like. Would you say that metros are also, or some metros are or are also high burden districts themselves?
For sure. So traditionally, the metros have been hotspots. Now, typically the resources tend to also congregate in the metros. So, the resources have been going there to a large extent, but you're absolutely right. HIV feeds on, if you like, people who are migratory, people who are moving, people who aren't necessarily engaging in care all the time, and people who are disenfranchised, I suppose, and not necessarily able to spend time on self-care or self-awareness. So in those settings, we really need to work doubly hard to find them, bring them in, engage them. And again, this is largely what the implementing partners using Pepfar dollars have been doing. The rural areas provide a different kind of complex problem in that here you have vast areas, you can't concentrate your resources because you actually have to get them far out and available. And so, again, over 25 years, the country has got quite good at understanding where the problems are and responding in ways that are very important. And for the first time now in 25 years, we really have an amazing array of tools, both in primary prevention, but also our treatment has become so much better that, if we just had more time with these resources, I think we really have a chance to bring this epidemic under control. But this haphazard kind of removal of key resources, I think, almost certainly is going to set us on the back foot.
And I'm glad you touched on the issue of resources and the haphazardness that tends to characterize the management and allocation of resources. Only recently, the Auditor General, for example, issued a report on the city of Johannesburg about how resources are being mismanaged. In fact, only this morning, one political party was asking for lifestyle audits of people who are involved in these things. Because one would imagine that proper, efficient management of resources, in other words, in the example I'm making of the city of Johannesburg, a proper, efficient management of resources and facilities would go some way, one would imagine, to help make up for what we are losing or what we're bound to lose through the withdrawal of funding by USAID.
Yeah, I think, you raise a very good point. How can we do this with fewer resources and more efficiently? And I think, some of the work that these dollars have been putting to good use is helping us understand how to realize those efficiencies and to make the most value out of the money that is available to us. Now, when I look at our health system and the difficulties we face, there's no doubt in my mind that we're going to have to make some very strategic decisions about how we spend our health dollars and make it last and get the best bang for the buck. So, we've put out some suggestions such as, can we offer people multi-month dispensing? In other words, could they get 6 months of their drug supply if they have demonstrated that they can manage their self-care very well indeed? So there are components of this where we can get smarter, use the money more efficiently, whilst we don't give up and lose the important resources to make sure that we shore up the populations or the individuals who are struggling more and need more care and help.
Professor Linda-Gail Bekker, let me thank you very much for your time. She is the CEO at the Desmond Tutu Health Foundation.